we have one of the
Okay, we're setting up now. It's going to be in just a couple seconds. I'm going to check. All
I
right.
saw it. I got them, Ron. So welcome everybody out in Facebook land. You've reached AB1400 CalCare office hours. We're going to be starting in about 6 minutes.
Oh, there you are.
6 minutes. So stand by.
All right.
Or listen in on our pre-chat, whatever you'd like. Carol Federa is here at the other link, but Carol, I'm not sure if you can hear me, but we are at this other link.
Okay, I see Danette's in here.
Carol.
There's Danette.
Hey,
Yeah.
how are
Hi,
you?
Danette.
Hello.
Starting.
All right. So, oh, by the way, Nina Turner was just on PDA, and she is running on a healthcare for all, obviously, in Congress, which was very exciting.
She was on
And
fire.
she had a lot to say, and so we're all hoping that she wins, right, Danette?
She was incredible. I mean, she always is, but I don't know where the woman gets the energy. She's just like the Energizer Bunny. And just I always feel better when I hear her talk. Like I can be in the doldrums. I'm like, you know what? We still got some hope. You know, so
I'm telling you. I mean, every single time the woman, she almost makes me cry.
I know.
I have cried. I mean, I'm not even gonna lie. She has brought me to tears a couple times.
Yeah, it's like going to church, but even better.
I think she is a pastor.
She's a daughter of a pastor.
Daughter of a pastor, yeah.
She's amazing.
Oh, she really knows how to get the crowd going.
And
Yeah.
Shervin's great too. He was like afraid to follow her, but I think he held his own.
Shervin was amazing.
He's really good. I like him a lot.
You guys know who he is?
We're running for Congress.
Right.
It's
Yeah, it's
Brett. I wish he'd take on Lou Correa. Can we convince him maybe to? Correa's worse than Sherman. But...
So anyway, there was an article, by the way, in the Times, which I found interesting about a lot of doctors who make big mistakes, and sometimes based on profit, you know, because it's a cheaper route, have injured their patients, and then the medical review board would have them, but they've never really, you know, they suspended them for a little while, but they never got revoked their license. And so it was an interesting article on that. So, but again, I think there's a lot of profit driven mistakes, you know, so that's an interesting topic too, that doctors being forced to pursue a treatment that's less expensive to the insurance company, but wouldn't do the patient well or may even harm them.
I wouldn't doubt it. Wow.
Right. So that was.
I mean, well, I mean, it's really, you know, I don't think a lot of, and I mean, granted, I can't speak for them. I just know the situation, having been in it. I can't say it's intentional, but the pressure is on these physicians to route to certain places, to do certain things within, you know, still within the current regulation. But yeah, I mean, what it is that the system gets so clogged. So let's say, you know, not trying to go down the capitation road, but, you know, if we have a cap provider or a specialist, and we're sending all these patients, like I like to use GI doctors as an example. There's a lot of patients who have GI issues, liver, you know, gastrointestinal, whatever's. And if you have a cap provider, like this one group, for example, let's say is capitated, and you're in a managed care world, a HMO world, or managed Medicare, Part C, whatever, and you go to this cap provider, you go to this cap provider. And so let's say you're sending all your referrals to capitation, because the way utilization is going to work is that capitation, they're going to refer the patients to capitation first, right? Because cap, we're paying them a monthly fee, or like monthly for just no matter what, you're getting that same money in your pot. And so we're going to utilize you. We don't want to send people outside of the cap, right? Because that's at the same time, it's what we call a capitation leak, and that's a waste of money. Because now we're not only paying this doctor a set rate, we're now paying another specialist a fee for service rate or whatever, you know, because they got referred outside the cap. So that's a leak, and that's reported, it's a mess. Anyway, but then let's say that capitated provider has maybe 3 or 4 specialists in their office, in their group, and now they're backed up. And so, you know, if you come into the hospital with some type of GI issue, might not have been resolved. And one thing I do want people to understand, and I know we're 1 minute to really getting started. Hospital management, we're going to take care of the acute issue, right? And we're going to then discharge you for further follow-up. So you might not all the time leave the hospital with an exact answer for what's going on. We've taken care of the immediate life-threatening issue. And then we're going to send you for follow-up. And that's why follow-up is so important. And that's why if the system itself is broken, that's where we lose you. We don't lose you in the hospital, we lose you in the follow-up. So if you came in with that GI issue, we took care of the immediate thing. We corrected your electrolytes, you stop pooing out the wazoo, you're good for now, right? But we're gonna say, okay, follow up with the GI specialist in 1 to 2 weeks, because we're not 100% certain exactly what this is. You might have colitis, or you might have Crohn's, you need further workup. And well, if that capitated, you have an HMO and they're capped to a GI, well, if that specialist office is backed up a month, and I told you to follow up in 2 weeks, you no longer have access to me, your case manager, who requested that appointment. I request the appointment and that's it. You're going, you know, they'll contact you. Some groups are good. Some groups do have outpatient case management that are good on follow-up. All of them have it, but the follow-up is the problem. So make a long story short, follow-up is where the system is really, really broken. And that's why we see these exacerbated catastrophic cases that have gotten way out of control for something preventable, like cervical cancer, like, you know, colon cancer. Not only are patients bad on screenings, but then the follow-ups that happen after they get diagnosed are very, very poor. And it's really sad. Anyway, it's 5:05.
We should, oh, chat is disabled.
I see it.
Huh, oh, it might have been on my other, on the other one. Oh, that's interesting. So, well, I think we're ready to start. Hopefully this will become clear to others what's happening. So welcome everybody to edition about 17 of our weekly AB1400 CalCare office hours. I am one of the regular co-hosts, Dr. Ron Birnbaum. You'll hear from our other regular co-host, Jeanna Harris, RN extraordinaire, shortly. CalCare Office Hours is a joint production of Physicians for a National Health Program, Southern California chapter, and Healthcare for All Los Angeles, Healthcare for All Los Angeles. Both groups committed to single payer, and in particular in relationship to this activity, this bill, both committed to doing single payer in California related to a bill that is in front of the California legislature right now, which would be a better system than we have. Current system is bad. I'm going to turn it over to Jeanna. Welcome everybody who's here in Zoom, and welcome people who are out in Facebook land. Welcome to you all. We are mostly about answering questions, asking and answering questions, but we do always want to start with like, well, what is AB 1400? What is it? What Jeanna, what is it?
A cute thing. No, AB 1400 is a guaranteed healthcare for all act here in California. And so what I'm going to share is our 7 basic principles. I go through this every Sunday, and some of you guys who have seen this and who are watching know this, and you should know this by heart. I should know this by heart, but I don't. And I like to read along. So thank you, CNA, for this graphic. CNA has been an integral piece of this legislation from the very, very beginning, putting that first ink to paper. CNA was there. So we want to give a big shout out to our nurses because where would we be without them? Anyway, so California's guaranteed healthcare for all is the solution to our broken healthcare system. If you just heard me talking right before we got started about a broken healthcare system, I was just giving you a real life example of what's going on. And so it will guarantee healthcare as a human right in the state of California. This is very similar to Medicare for All, which is something we'll talk about here in a second too. This provides universal coverage. So we're talking everybody, a body that is every, is in and nobody is out. Everybody, a body that is every, is regardless of your race, your sex, your gender, your country of origin, disability status, immigration status. If you are a California resident, you're going to get the care that you need regardless of your ability to pay. This is a single public program. That's what single payer is. Publicly funded through progressive taxation. I know we're taxes, we get down that road, people automatically clam up, but think of progressive taxation as Bezos and the billionaires pay more than you, okay? And as they should. I can't afford to pay, what Bezos pays in taxes, even though the current system has that kind of reversed. But anyway, progressive taxation to cover the necessary care in California. This is also going to help eliminate, the single payer helps eliminate billions of dollars of bloat and waste and save the people, you, me, all of you, thousands of dollars on their healthcare costs. Going back to what I was saying about the, clogs in the system, the poor follow-up care. A lot of that billions of bloat and waste is lost in the administrative tube. And that administrative tube is a little unnecessary. It just doesn't make any sense. So with the single payer program, it's more of a direct payment from the payer source, which would be California, to the provider. No more insurance picking off here and then go pick off there and all that stuff. That creates slowdown. Anyway, fully comprehensive benefits. We're talking medical, dental, hearing, vision, mental health, prescription drugs, long-term care, and more. This is actually more than what Medicare provides at this point. This is a kind of accumulation of all the public programs under one umbrella, which should have been this whole time, but I'm not in charge around here. Anyway, all decisions about care will be made between you and your doctors and nurses, not the insurance companies. Once again, your care should be between you and your provider. An insurance company is not a provider. They're more like a regulator of providers. So you should not have someone in an insurance company telling you that the care that your doctor is deciding you need should not be able to happen because they're not a provider. Insurance company does not provide care. They're more just like a faucet. They can open it up, they can turn it off. They can open it up, turn it off, but they're not providing the care. The water, just like in a faucet, the water is always there, but it's when you turn it on, it flows. When you turn it off, it stops flowing. And the insurance company is the one turning it on and off. And unfortunately, they like to keep things at a slow trickle, and that's not cool. Freedom to choose your care provider. Under CalCare, there will be no more in-network, out-of-network. You're going to have the freedom to choose the doctor or hospital you like. We've talked about this before about, well, wouldn't the most popular doctors and providers and hospitals be the ones that get flooded with all the patients? Actually, probably not. And maybe in the middle, and somewhere in the beginning, possibly. A lot of people are going to want to go to our big tertiaries hospitals like UCLA and Cedars. But at the same time, a lot of patients can't get there. And if you know LA traffic, nobody's going to be driving from Long Beach up to UCLA unless they really need to go there. Nobody's going to fight that 405 that long. So if they really need it, though, they shouldn't have to worry about, well, is UCLA, Ronald Reagan in my network? If they need that tertiary care, if there's a specialist there or a provider at UCLA that patient in Long Beach needs that's not in their immediate area, they should be able to go see them without worrying. The first thing, are they in network? And you have the freedom to choose, like I said, hospital or doctor. If you don't like your PCP, but you feel like you're stuck with him in a very bad relationship, you should be able to go and say, you know what? My friend, or I had a recommendation to this doctor. You should be able to call that doctor, ask them if they're available to see new patients. And if they say yes, that's all that should matter. And then you go develop a relationship with a new doctor. Because the one thing about keeping you healthy is making sure that you trust the provider that's taking care of you, right? So you shouldn't have to sit there and worry about what provider is taking care of you and be restricted by the network in a bad relationship with your doctor. We want you to be healthy. And the key to being healthy is also being able to trust. Free at point of service. No more copays, premiums, deductibles. You arrive at the doctor's office, you show them your CalCare card, and you get the care that you need. It's that simple. That simple. You get the care that you need. Like I said, we're not talking about a bunch of extra stuff. the care that you need. If you need to have an exam done, or, you know, that's outside the norm and you need it, you should be able to get it done without having the co-pays or premiums, deductibles. That shouldn't be coming out of your thought process. That should just be like, I need to have this done, and okay, I'm gonna get it done. And then you leave a healthier, happier person. Just transition. So what's going to happen to those people who are working in the insurance industry anyway? Well, because unions like CNA, who think of their workers, have thought about this and wrote this into the bill, that funding and programs to protect and support any displaced workers in the insurance industry. It's called Just Transition. And we're going to see, you're going to hear Just Transition come up a lot more as we're moving to a greener, cleaner California. You know, we're stopping a lot of fracking and things like that. So what's going to happen to those people who are, you know, kind of working on those oil rigs, who are working on in those wells and things like that? Well, once again, I always say this, the workers should not suffer due to the bad leadership. They've known climate was a problem for decades, but guess what? They kept doing it, but that's not the worker's fault. The worker has to pay their mortgage. They have to pay their rent, take care of their family. So this bill is going to include a just transition. And like I said, you're going to hear about it more. As you know, once AB 1400 passes and we start building this out, we're definitely going to be looking out for those workers. They will not be left out in the cold. Not only are they going to have the funding and the programs, guess what? They're also going to get a little health care, and they won't have to worry about all the extra fees associated with it. Patient care based on patient need. No more financial incentives to avoid providing necessary care. And so that goes back to what I was discussing before we got started, which is, you know, routing care to certain providers due to contracted rates. Well, this contracted rate is cheaper than that other provider. That provider may be able to see you tomorrow, but their rate is higher than this provider that it may have to be a couple weeks before they can get you in. No more of that. So, you know, while you don't see what they used to in the old school system, a lot of like pay to play stuff, there is a lot of issues with contracted rates. And that contract goes between the provider and the insurance company. And then of course, the insurance company is going to want to use the best rate, because why they consider you a beneficiary, you're about, in that word beneficiary of their, you know, product, you're about 20% of that, and 80% is probably the stakeholder benefit. So just putting that out there, now you're going to get that care, and there's not going to be any financial incentives for them to avoid providing necessary care. And once again, in a long-winded way, that is the CalCare 7 basic principles. And fun. And I'm going to stop sharing.
Nice. So, you know, you mentioned something towards the beginning that I wanted to seize on a little bit, but as we move into our question and answer period, but just about Medicare. So a couple of things are making me think about Medicare. And so one is that sometimes people will use, and I think reasonably so, as interchangeable ideas, single payer healthcare and Medicare for all. And July is the anniversary of, July 30th actually is the anniversary of the Medicare program. And so I wanted just to mention, but also kind of ask a question. So one is that in some ways people would say doing AB 1400 is like doing Medicare for all of California, Medicare for all people in California. And so one thing I just want to mention is there's a big Medicare for all march that's happening. There's happening in more than one place in California, and certainly in the one that's happening in Los Angeles. This is going to be July the 24th. AB 1400 is going to be featured, and some of the authors of the bill, for example, will be speaking live, and there'll be all kinds of other cool people, including Jeanna, who will be speaking at the Medicare for All March. But I also wondered, before I asked the question, or threw this question out there for discussion, does anybody who's on the call have some and who has a better connection than me. Can you put some of the information about the march, either share it on the screen or put it in the chat for people?
I will. Actually, I had pulled up the graphic, but I didn't pull up the actual info, but you know, I can drop the links. I just want to I do want to share this graphic because it's beautiful. And I want to give a shout out to Healthcare for All Los Angeles, very own Bronwyn Major, for creating this beautiful, 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 very beautiful graphic. I love the graphics, and I think I said beautiful enough, but this is the March for Medicare for All Los Angeles. We do have them taking place in, I think, San Francisco, the Bay Area, San Diego, Orange County, right? Dr. Bill, is there one going on in Irvine or
I
Irvine?
believe so. I think
Oh,
so.
actually, you know what? Actually, let me do you one better. I had the website up. So I had all the March links on there.
There you go.
Jeez, I'm not smart. Anyway, so here, can you guys still see my screen?
Yeah.
Fantastic. So here we are. Look at all these cities having marches for Medicare for all. I wish they were all for AB 1400, but this is AB 1400 is just a statewide. But look at all these cities from
We're just-
Albuquerque. Huh?
We're just seeing your graphic.
Oh, okay. Sorry. Let me do this again.
Good graphic, though. But actually, while you work on it, I could throw out this question. Oh, okay. Let me not throw out that question.
I've gotten so used to this thanks to COVID. I'm just like a Zoom master. But you know, so yeah, look at all these cities. I mean, Albuquerque, Honolulu, Hawaii. Shout out to my lovely lovelies over there in Hawaii. I will come visit one day. And Huntsville, Alabama. And when I saw Huntsville, I thought about Alabama because they have a very low COVID vaccination rate. The South is not doing too hot on COVID vaccinations. The South doesn't do too hot overall on healthcare and public health, period. A lot of it, you know, people have their opinions. But the fact Huntsville's doing one, I just want to give a shout out to Huntsville because it is so, so needed there in the South. And then here we are, Los Angeles. Look at that, Little Rock, Arkansas. I mean, anyway, it goes on and on. Look at all these places throughout the country are having Medicare for all marches on the exact same day. I can't say same time because of time zones, but I don't even know where this place is. Bemidji, Minnesota. But shout out to Bemidji.
Bemidji, yes.
Shout out to Bemidji.
But wait, within California, I thought I saw.
So here's Irvine.
There's Irvine, there's LA, there's San Diego. I saw down there.
San Diego, San Francisco.
And San Francisco. But for those of us who are in LA, I think Paul Newman just put in the chat the LA thing. And yeah, and there's the, you know, you can say you sign up for this march, but it's so you get all the information. Mm-hmm. And it's a several hours because it's like it meets at Hollywood and Highland, right? And then there's some people talking, and then it moves around. It goes by CNN because they're gonna like bring it to the mainstream media. What's going on with this effort? And so, but let me in thinking about the march, there's maybe two questions that I wanted to throw out there, and I'll just throw them out. So, question one is, well, what if I have Medicare? I don't yet, but like my parents do. What would happen to them if California adopted AB 1400? And the other thing is, let's say you believe that single payer would be a good thing to do both in the state or in the country. How, and because the march is also dedicated to that idea too, right? That it should not just be in California, but be everywhere. How would AB 1400 sort of like play into a national movement? And so these are sort of broad questions, but throw them out there for anybody who wants to pick them up, who's with us today. Anybody?
I'll start it off. So if you currently have Medicare, you know there's gaps, right? And AB 1400 helps fill those gaps. It provides you long-term care. Medicare does not provide long-term. They will provide skilled nursing. So if you need like a nursing home for a short period of time for rehab, you had a hip replacement, need some more therapy, you know, for a short period of time, Medicare will cover that up to 100 days per benefit period. A benefit period is, like I said, 100 days, but you have to be out of the acute care. Like if you discharge, you spend up all 100 days and you leave the nursing facility and you need to come back to a nursing facility in a week, guess what? You don't have a benefit. And I have faced that so many times. You do not have a benefit and there is nothing I can do. Except, you know, private pay, and that's $600, $700 a day at least. And so, you know, so that gets taken, that is absorbed into AB 1400. So that's plus number one. Plus number two, vision. I just got fancy new glasses, and vision is a big thing that plagues our elderly as we get older, especially, I mean, my generation, we're really screwed. All this digital technology, all this stuff, we're going to be blind as a bat by the time we're in our 50s. And so we need vision, and Medicare doesn't really cover vision. Now, Part C, Medicare Advantage, sometimes some of the health plans to entice people to come hither, they will include certain vision benefits, but not really, like it's really, really crappy. So, you know, vision really in regular original Medicare vision is not included, neither is dental. And those two things are really needed by our elderly because, I mean, teeth get rot. I've seen teeth rotted out to like almost the core. They can't even eat anymore. I've seen, you know, and that happen and then they not have a dental benefit. So what has to happen, and this is very much so more expensive, by the way, we have to route, instead of sending them to a dentist, we have to route them through an oral surgeon, which they needed anyway by then, because they have to have that whole extraction done. It's infected in the bone, and now you got to have grafts. And yeah, anyway, so we have to route them to an oral surgeon because Medicare will cover oral surgery in like in a maxillofacial surgery in a hospital setting, but it will not cover dentistry. Isn't that crazy? And so which one do you think is more expensive, going to a dentist for a routine checkup or having an oral maxillofacial surgeon see you at a hospital and having to have a procedure under anesthesia? So once again, another great thing. So that's a third plus of having AB 1400 over just having regular Medicare. You still get your freedom of choice. You still get to likely still continue to see your providers. But those just going into those three are so important for our seniors right now that I don't even feel like I need to go to anything else. I should have sold you by now.
I see Dr. Bill has his hand up.
Yeah, so you know, in the movement in general, we talk about expanded and improved Medicare for all, not just Medicare for all. So it's never just Medicare. And, you know, a lot of us are waiting, some people really hanging on for dear life to get Medicare. To actually become 65 so that we qualify for Medicare, which we shouldn't have to do to begin with. You know, what is that arbitrary age, right? To where you finally become 65 and qualify, you know? So there's that whole issue. But once you get Medicare, why doesn't it include all of those things that Jeanna was talking about? Why are there still significant out-of-pocket expenses in Medicare, like supplementals and copays, and especially pharma costs, prescription drug costs are huge for seniors. It's a big part. You know, seniors are what you call fixed income. A lot of retirees, people living off Social Security, which is really inadequate. It's like a non-living wage, you know. It's like below minimum wage. How do you live off Social Security? Well, I guarantee you don't live very long, especially if you have prescription medications you have to buy. So what expanded and improved Medicare for all, or in this case, when a state does it instead of waiting around for, you know, Mitch McConnell to get over himself. When California takes it over and does AB 1400, then there are no out-of-pocket expenses anymore. There are no supplementals. There are no copays. There's no parts A, B, C, and D anymore. It's covered by the state of California covers all of that. And that is significant. When you sign up for Medicare, your out-of-pocket worries don't go away. Unfortunately, there are still way too many out-of-pocket expenses. And that's what we're talking about. That's what FDR had in mind. You know, that's what LBJ had in mind for seniors. And, you know, FDR, of course, had it in mind for everyone. LBJ got it for seniors, you know, because there was a feeling that seniors shouldn't be made to live off of, you know, scraps and peanuts, you know, in their golden years, because they were spending all of their money on healthcare, you know. So so that's what we're talking about here. It's not just Medicare, it's expanded and improved Medicare, and that's good for seniors. It's also good for folks who are on, you know, who are disabled, who have kidney disease or blind. So then they and their families don't have to come up with supplemental costs as well. And those are considerable expenses. It's cost shifting, and that happened largely during the Bush years, mostly George W. Bush, not H.W. But during the Bush years was when they started those supplemental costs, so in parts A, B, C, and D in Medicare, and they privatized Medicare to start Medicare Advantage and other parts of Medicare that then, you know, siphoned profits out of the trust fund that is Medicare. So so we're talking about the state, in this case, the state of California, assuming all those costs. Now, why and how can we do that? How can we possibly do that? We're the 5th largest economy in the world. We can do that. We can have a better healthcare system than Canada. We're about the same population size as Canada, but we have a bigger, more robust economy than Canada does. So we could do that in California. Economists all agree on this. The economic science has been studied over and over again, always comes to the same conclusion, as does the social science. So it can be done. It's good for everybody, and it's economically feasible as well.
And I'll just mention, since you mentioned Canada there, Dr. Bill, that you know, Canada does have a single payer system. It's actually called Medicare, and some people here will know the history of that, which is that it did begin in one province, so that which was Saskatchewan, that's right.
I just like saying it because I learned how to pronounce it popularly, that's all.
Say again,
Saskatchewan?
Saskatchewan, yeah. Thank you, Saskatchewan. We seek to be the Saskatchewan of the United States here in California. In California. So but I think that's part of understanding, you know, like with this march that's coming up, you know, there'll be people who will be talking about doing Medicare for all, or expanded and improved Medicare for all in the whole country, and also people talking about doing it in California. They'll be focused on AB1400, because AB1400 is the way to do it here. And maybe if we do it here first, then that will lead the way, as we so often do in California, for bigger and better things throughout the country. So how are we doing with questions? Do we have any in Facebook or in the chat?
Oh, wait. Oh, sorry. Thanks, Paul. From the chat from Hai Ching. How do we get, the CNA flyer for Medicare, for the CNA flyer on the point for Medicare for all. And so I think, Paul, I saw you already put that link in the chat for her. For the drive to the toolkit. CNA has a lot of great flyers and social media graphics and things for Medicare for all. We also, Healthcare for All Los Angeles also has created a lot of graphics, but that one sheeter for the 7 basic principles is a very, very basic way to share with people who are not familiar, who are not in this single payer world. And it is pretty simple to understand. So we really like it, because it takes this 60-something page bill and puts it onto one sheeter of what it is and sums it up pretty well. But we know, and I've been thinking about this a lot, we know there's going to be a lot of questions that that will not be able to be answered on that one sheeter. So if you guys are watching, if you're having this conversation in your community and you get asked a question that you may not know, that's what we're here for, number one. So please bring it back to us. And if we don't know it, we certainly can find it out. I love being we love challenges around here. But at the same time, this bill is a frame of a house, and it can be a very nice house. But it's a frame. And so some of the questions that even our elected officials are asking I will not be able to quote a section in the bill for it quite yet, but that's because it's a frame. There's going to be insulation that has to be put in. We're going to have to, paint the walls and get the drywall. We're going to have to decide what color schemes we're going to want. All of that stuff will happen once AB 1400 passes. Right now, our goal is to get this passed. So that we can start building that house, so that we, I don't know how much of we, but the board and the committees will be able to sit and start really talking about, okay, now we've got the frame, let's build. And then that's what AB 1400 is. It is not a, one-stop shopper. It is literally the frame, but it's a very strong frame with a nice, good foundation. We are not building houses on sand here, people. This is a very, very good foundational and frame. And we want to use it, but we have to get our elected officials to say yes to using this frame in this bill.
Again, was there anything from any questions out there from Facebook or the chat here?
I'm watching, but I haven't seen any questions yet. But I think I think there's still a lot for us to learn about AB 1400. What are some of the elements, for instance, that are running against us? Like the other day, I heard on a radio show, this woman check in, and she talked about whole Washington, which has their version of AB 1400. And she was saying that she had relatives from Uruguay, from South America, where they have single payer, and it's not working and everything, and it's not good, and she's afraid it's going to really look bad. And Ro Khanna was the guest, who's our congressman for California, one of the congressmen, Ted Lieu and Ro Khanna, and it was just unbelievable. It almost as though she was trolling them. So there may be some elements that are, that are starting to penetrate the media now.
So this is my best response to that. Of course, people always want to bring up, when we talk single payer, national healthcare system, anything like that, they want to talk about delays in care, long wait times. I worked in a trauma center as an EMT where we had 8-hour waits. Current system, 8-hour waits in a county hospital. So you want to talk about delays in care, it don't get no more delayed than that. And actually, it can get even worse on a hot summer day. And Dr. Bill, I know that you know that. So, but what I want to say is that even the best legislation, the best healthcare system is vulnerable to bad leadership. Going back to what I was saying about the worker should not suffer for bad leadership, nor anyone. So that is where civil engagement is going to come in. Now, when AB 1400 gets passed, I'm saying when, because I still have to take Gavin on our date to in and out so I could lobby him for AB 1400. So when it gets passed and he signs it, that means the board has to be created. It's 9 people, not chosen by the public, chosen by the governor, the speaker of the assembly, speaker of this, or the Senate pro tem, whatever. That is where people, activists like us, are going to be watching like a hawk. Even if we have to sleep out in Sacramento until we know who these people are going to be, we're going to be trying to influence that, because this bill is solid. This bill will work. But if we have the wrong people chosen to run it, and I'm just being honest here, I'm not trying to put any bad things or bad juju, I'm really painting just an honest picture. If we don't have the good people building this system out, then yes, we will have problems. But there are some really good people and that I hope would be decided or, you know, considered for these board positions and these committee positions, that like Carmen Comsty, number one, she's on the commission with the governor already. I hope she gets to be put on the board for AB 1400, you know. And so I really think that if we have the proper board that is willing to put in the work to build this out, then we can make a streamlined system. Will it be perfect? No. Nothing is ever is, and I will not sell anybody anything, because I don't want anyone coming to me in 5 years or 2 years or whatever and saying, you told me it would be perfect. You told me this. I'm not saying nothing is ever perfect. Yes, there could be a, you know, a drop or something, but the system itself overall, we're going to see such an improvement, such a cost savings that we will be able to invest in other resources that communities need that AB 1400 may not cover. And so at the same time, like I said, to answer that is to say that, you know what, we have to make sure that we stay on top of it. This is our system. We can't just say we want this bill and then turn our backs on it. This is our system. Each and every person, 40 something plus million Californians, this is each of our systems. So if we want it to be a certain way, then we need to make sure we have a voice in it.
Dr. Bill.
So, my answer to that would be fact check. that person, you know, who brings up some anecdotal fact has to be fact checked, and you know, you can't do that like in real time on a radio show. So otherwise, you have to say that is anecdotal information. Thank you for sharing, but it has no relevance in the big picture, because what we know about actual information like data, worldwide data that's actually shared, shows that single payer systems have better outcomes. And you know, and I'd be glad to show you that data, scientific data, as opposed to the anecdotal information that you just shared. I mean, I just looked up Uruguay. I just Google searched Uruguay, you said, right? And they have a mixed system. They don't have single payer. So that person was wrong in their assertion. You know, so you have to fact check those kind of allegations.
I would hope. Well, but so you could say then, based on, or thinking about Paul's question, based on what's certain things that are in the bill, who might be like naturally opposed based on like what is in the bill. And I think one big source of opposition would be health insurance companies, because the bill, the idea of single payer is that there's one main insurance company, and that's all of us. And that's actually, from a policy-wise, the best insurance company, because the biggest risk pool and the risk getting managed, or the decisions being made in the interest of the individuals and not based on profit or the bottom line of some insurance company. But you could say then, well, why would they look at this and be opposed, or why might they be opposed? And the answer is that there are stipulations in the bill that say that an insurance company can't sell insurance in California that duplicates services that would be provided by CalCare. So CalCare is the name of the system, the AB 1400. So actually the bill is not called CalCare. The bill is actually called the Guaranteed Healthcare for All Act of California, something like that. But the system it would create, sort of an analogy to Medicare, would be called CalCare. And CalCare would then have a defined set of benefits, which, as we've been discussing, would be more generous, certainly, than Medicare, and essentially all currently available insurance. I think that's right to say, or almost perfectly right. And because then insurance companies couldn't continue to operate where they would be selling policies that were like that duplicated those services. Well, it's not good for their business interests. But it just turns out that the business interests of the insurance companies aren't necessarily in the healthcare interest of the people of California. I mean, that's the problem, right? So that will naturally create some opponents. But and you might say, well, might it include some of the opponents? Might it include some people who are employed by the insurance companies? And that's a little bit why Jeanna was going into detail, I think, earlier about the just transition, which is that we know that if you put a system like this in place, that the people who work for those companies, I'm just talking about the people who are doing the daily work. So I'm not so worried about the CEOs of our health insurance companies. I'm sure they'll be okay. They'll find something else good to do. But the people who have been working in the insurance companies at the ground level, or the incredible army of people who work in healthcare providers' offices or hospitals, who have to deal with the incredibly complex billing, which is what is the case in California and every state in the United States, we will be able to find them better and cooler things to do than billing with the incredible complexity. Because where, for example, in Canada, where you have a simple, straightforward single payer system, billing is a much simpler activity. It's so much simpler that it just doesn't require that the same sort of armies of people doing that work. So, we think that we will make friends of people working in the health insurance industry because we'll look out for them, and they know that they're insiders at knowing how messed up the system is. So they'll like that. But yeah, there could be some opposition from the people who make the big money from health insurance. But we can't let that stop us, right? So, because yeah, they don't matter more than like the other 40 million people matter, right?
Exactly. And coming from that world, I can tell you that the average frontline worker is not going to be your opposition here. I mean, yes, they're going to be concerned about their job. But the minute when we have a just transition really planned out, I think that will be an easy discussion to have. But they're being stressed out and work. The turnover alone in these companies is so high. And I'm saying as someone who just got left. The turnover is very high. They do not last long just because of the aggressive quotas and management that they're under. And so I really don't think it's not going to be the worker, but it is going to be, of course, the company. It's going to be survival. We're threatening their survival, and we're threatening their stakeholders are going to, want to jump ship. I mean, can you imagine a company which will not be named with a, that has a share cost on the stock market of $400 a share? What may happen if something like this goes, what their stock price might happen, how many people just based on speculation will sell off and drop their stock price. That alone is a threat to their survival. And while we should not be talking about this, I should not be sounding like we're having a board of directors meeting for some Fortune 7 company, but that is what they're talking about. Not once have you heard me mention patient, life, compassion, empathy, anything. You heard me talk straight up numbers, and that is what's going on up there. Hate to say it, but Paul, I saw you put something in the chat. So I just wanted to see, it says, you understand that the board, wait, do you just want to say it? You're here. Why don't you just come off mute?
Okay, this one's from HC4US. Even though most things will be covered per our discussion last week, there are still some things that may not. I understand the board is who gets to decide in cases that are not clear cut. But how would an individual access information about their treatment or surgery to get covered after the fact? Does AB 1400 lay out a plan for a call center or something? I am asking because I just got a bill from Kaiser and I couldn't see what the charge was for on the website. And after 2 hours of trying to get help, over the phone, I had to give up. Was I clear?
Yeah. I know in AB 1400, it does, sorry, I've got way too many screens up, but it does talk about an appeals process, but it does not go that deep into detail about like how it would, like in its entirety. There will be an appeals process. There will be a process for your provider to, request treatment. Wait, did you find it? Where's my AB1400? So there will be a process, but I mean, in my world, if I once again was on the board and I would say, okay, we do need transparency and we have the technology to be that way. For example, when you appeal a discharge from the hospital under Medicare, you get to go through a third-party person called Levanta. Now, don't get me started on Levanta, but they're third party. They're not the insurance company. They're not, they're not Medicare. They're literally a third party reviewer. And they review your case for whether or not it's appropriate. You meet medical necessity to either stay in the hospital or are you ready to go home? That you get a case number when you file that appeal. You as the patient file that appeal, you get a case number. And that case number, you go to their website, you put in your case number and you see the steps, step by step, where is it at in the process? The problem, it's not extremely detailed. But I say that to say that the technology is there for there to be a system where you could, if you were, following a process or having to appeal appeal a treatment, there should be some type of transparency, at least telling you where you are in that process. It might not be extremely detailed. They might, you might not be able to see extremely line by line what's going on. But when it comes to like billing and things like that, we know we can do online billing. In AB 1400, is it completely written out? No. But that's because, like I said, what that question is kind of like that putting in that insulation. It's one of those other steps of building the house where we're still at the frame and the foundation level right now. And what you're asking for is a very good thing. I think it is something that's very important because I don't know how many people spend hours of their lives on the phone just trying to resolve something that's really kind of simple. But I think that it would be something that would be more worked on once we got the initial bill passed and the framework built out. But I think legally they have to legally have an appeals process. They have to legally have a review. So, I think that is something that will definitely be, more worked out after the initial bill is passed. And Dr. Bill, I see that your hand's up.
Well, thanks. So I love questions like this because they're like so many layers to the question. It's like, okay, so does this person have Kaiser, and did they go outside of Kaiser to get care? And did Kaiser consider it to be not legitimate care? Is that what the Kaiser who reviewed it, and is that why they're getting a bill? So, but Jeanna's absolutely right. The processes already exist. The systems already exist for evaluating care that's been given. And then the question becomes, whose responsibility should it be? Is it we've placed that responsibility in the hands of commercial interests whose bottom line is to make money for their shareholders and themselves? Or should it be in the hands of the public, and meaning we the people, where we select a board that does that, and the systems that exist already, like for example, the VA system, traditional Medicare, they do a much better job. They have excellent, better outcomes, and they review medical procedures and things that are done and decide, are these within the scope of scientific evidence-based practice, as opposed to commercial interest, where you get these kind of things where you can't get through, you get charged for something you had no idea you were going to get charged for. In our system, we're talking about things you would never get charged for. You're not going to get any charges for something, there's no network, so you can't go out of network, because everyone that you see that is going to be in network. Let's say you go out of state. Let's say you go get your, what do you call it, a Brazilian butt lift? Is that what I think Jeanna likes to bring up, the Brazilian butt lift? Okay, and you claim that that's reconstructive as opposed to just say cosmetic surgery, So why did you need a Brazilian butt lift? You know, and maybe you have to substantiate that claim. You got it done out of state or something. So then our state board is going to review the claims from that out of state entity who actually performed that. You know, I personally would trust our state board to review that, not some commercial insurance entity to review that. And, you know, a lot of people don't trust government, you know, in those kind of functions. And I get that. I get that. But the science shows over and over again that when it is the public deciding, then these decisions are made and, you know, with better outcomes and saving money. And that's what we're talking about, is saving money and saving lives.
And
Go ahead.
No, and I think that, like, overall, I mean, healthcare is a complicated activity, but we complicate it tremendously by our crazy non-system that we have now. So in general, a simpler system is one that's easier to ask questions about. It's an easier place to get information about what's going on with something or other. I think that that's inherent. I also agree with Jeanna that not like, you know, the color of the wallpaper at CalCare headquarters hasn't been chosen yet. In other words, there's certain things in the bill are not in the bill, but will be in the implementation of it. And I think so some of those details of like how exactly does a patient kind of ask questions about their like care and their like their situation, and what's, you know, is there something that's at the margins of covered or not, and where their thing would fit in. I think some of those details would still be worked out in the bill. And I mean, I think anybody who has ever, you know, had some experience of like, sometimes it's hard to get some questions answered at government agencies, but let me tell you, it's super duper hard right now, as the questioner had said, to kind of penetrate often what's going on in the health insurance companies. And there it's often because of a committed effort to make it hard to get questions answered. So the bill does, so this is a slightly different issue. It's also sort of like how do people give like input into what needs to happen with healthcare. And the bill does have a very specific requirement, which is, it's actually on page 19 of the bill, which is to establish a process that is accessible to all Californians for CalCare to receive the concerns, opinions, ideas, and recommendations of the public regarding all aspects of CalCare. So that sounds like it's more about the issue of not like one person's their particular situation, but somebody saying like, we need to be doing something or other differently. But right now, it's very hard to make that kind of input happen anywhere in our healthcare system. Right now, there's sort of no mechanism to impact the system for a lot of people. It's often hard. I mean, even the, you know, kind of free market approach to you don't like how something is, which is you know, leave that insurance or say, we're going to take that insurance somewhere else. That's like really hard to do under our current system. Like if you don't like something, like most people don't have some choice of healthcare plan. They get, for very many people, if the biggest source of health insurance is still employment, still people's work or somebody's work in the family. And that very often, like, you know, from I get my health insurance from my wife's work. She's in the Writers Guild. They have Anthem Blue Cross. And if I don't like it, tough. Like I can't change that. And actually, she's on the health benefits board for the Writers Guild. And it's not just like an easy, so she's really involved in that level of stuff. And it's still not like she can just be like, oh, we're going to switch off of Anthem Blue Cross tomorrow. and switch everybody to something else because we don't like it. So, you know, it's also worth, I mean, already the person who was asking the question was like, our current system, there's problems with that kind of thing. When you can't kind of penetrate a bill or why did this happen to me the way that it happened? It's sort of one of the many reasons to go to a simpler system. Well, I'll leave that baby there. Is there a question? Yeah.
Yeah, there's a question here. Paul just dropped. So why do hospitals charge so much currently for a 3-hour visit? Sutter Hospital charged $44,000. Will AB 1400 reform this crazy pricing? Ooh. Yes. Yes. Like Dr. Bill, yes, and that's that. But yeah, no, it is the wild west on pricing right now. And I know that, who was it that has a really good breakdown of this like pricing? Belk. Yes, I think it was Belk, not Jim. It wasn't Connor, it was Belk. And he broke it down about the difference in pricings and the reason. I mean, it's profit. I mean, granted, there are some other things, like if you're a certain level center, you get to charge a little bit more, and you know, you get certain accolades, you can charge a little bit more. And there are ceilings per se, like Medicare rate, like for Medicare, you know, people, it's just, but it's still the Wild West on pricing. And Dr. Bill or Ron, if you guys want to chime in on that, because I can't tell you where pricing comes from.
I do want to say, and a couple of things about that. So one is that, you know, there are for-profit hospitals and there are also not-for-profit hospitals, and the not-for-profit hospitals still will charge crazy things like that, right? And some of the reason is that, and it can very much distort kind of the nature of inpatient medicine, like when people get hospitalized, but essentially they're billing for every single thing that a patient gets done for a patient. And that can be like that they have a headache unrelated to why they're in the hospital, and the nurse, there's a little thing that says like, oh, give them a Tylenol as needed for headaches. Doctor writes that order, a nurse brings a couple Tylenols, and then a $40 bill or something for those Tylenol will appear, and it'll be like, it had to be carried over by a nurse, it had to be pulled out of a machine, the hospital had to buy some Tylenol, probably cheaper than $40 for the 2 Tylenol. But that's just one example where every single thing at most hospitals gets billed through, and so it also leads to really crazy kinds of medicine. So I'll give you a really sort of close to my heart thing. One of my roommates from medical school, so I'm a doctor, one of my roommates from medical school is a fantastic physician named Jonathan Reitman. And Jonathan is an internist. He's a general internist and does hospital medicine and outpatient medicine. And when Jonathan, and he's brilliant. I mean, you know, and he can figure out like most things. I mean, he's not a surgeon, so he can't like cut your appendix out if you need that in your hospital stay. But he is really good at figuring out a whole lot of stuff and himself. But when he works at hospitals, people who do his work as a kind of hospitalist generalist are under tremendous pressure to kind of get, like, when they admit somebody, they'll hear like about all, like maybe different problems that the person who's admitted has, and then they're sort of forced almost by the hospital to call a consultation with all these other specialists, right? And it's not that they don't, you know, he would never do that sometimes get the help of a specialist in the hospital. Of course he could. He's almost forced by the system, because each one of those specialists who comes in generates like another bill. They'll get paid, but the hospital will get it's just a system that's built on, in that sense, on overdoing it. And then you see, and you'd think that the insurance company wouldn't like that. This is part of the belt thing, right? And at times they're worried about certain things that cost way too much money, so they'll want to restrict those. But it's also true that as part of the Affordable Care Act reforms, where they're allowed to kind of keep, there's this thing, the medical loss ratio. So the amount of the insurance money that's given to their premium money that's given to the insurance company, they have to, they can only keep, or like 85% of it has to be spent on healthcare. So their 15%, if more gets spent, that 15% is actually bigger for them. So in some cases, that's one of the belt observations. So that they then, you'd think they'd have an interest in keeping those costs down, but they actually have an interest in sort of more in certain settings happening, because their piece of that pie, their 15% piece of a bigger pie is bigger. So, what the bill does is to change completely how hospitals are paid, and they would be paid with what are called global budgets. And that's a lot more like how the fire department down your block from your house, or the local library, or the main branch of the library, or whatever, how government does their budget. They figure out kind of what they need to operate for a year based on past experience, maybe expected or possible changes, and then they're paid a big lump sum. And then the whole thing of like giving services that people don't really need, or inflating costs artificially, all that goes away, and the whole need to track every item as it goes through the system to create a part of a final bill that can be enormous. Well, that's something that AB 1400 would end, and other big single payer bills often take a similar approach. So that's really important to understand with the bill, is the idea of global budgets for institutions. So like institutions get a global budget, and that's not a rigid fixed thing. That's a dynamic thing. That's something that is a kind of continuous process of year after year of refiguring out what a place would need, even within a year, the ability to ask for extra funds if there's special situations, like maybe you have a pandemic of a respiratory virus or something like that happens, and you need some more ICU care, right? So, well, that costs certain things, and so that's something that the bill anticipates, that not everything can be anticipated. So I also see Dr. Bill's hand up there. Dr. Bill, you have some thoughts on kind of the crazy hospital bill thing?
And of course, what do I have to share with everybody along those lines?
A bowl of spaghetti?
The spaghetti monster, the flying spaghetti monster. If that's okay, I will share.
Yeah.
That.
Oh my God. Yeah. That
So,
thing.
this is what we're talking about. Can you all see that?
Yes.
Canadian versus American style for how we pay for healthcare, right? So one is a bunch of spaghetti thrown at a wall, or the giant flying spaghetti monster. And which country is that?
Yeah.
Us, US, us. No, here's the clue. Here is provincial, so that's Canadian, And this is not just waste. I mean, every little square, every little box, every arrow that points from one box to another, this is where you submit your claim. This is where your bill is paid. All of these little squares and boxes and their connections are real. And there's probably 4 or 5 layers of this nonsense that couldn't all fit on one page, compared to the way they pay in Canada. And you'll see in here hospitals and clinics, and and this is not just waste, it's also fraud and abuse. And but going back to waste for a second, I like to focus on what Jeanna said at the very end of what her comment was that she doesn't know. She works in the system. Jeanna is an expert on medical billing, how it translates from actual care given to a patient. That's why she is an RN extraordinaire. So she is a registered nurse, knows what it means to get actual care. That's the kind of person we need. We need RNs, MDs, technicians of all kinds, right? Because they actually do the care and understand what care people need. Okay?
Can I add that nurses don't get to bill separately? Physicians do, anesthesiology does, the lab bills separately too, which is crazy. Nurses don't get to bill separately. I'm starting to feel some kind of way about that.
That's right. But what I really liked about what you had said was that you don't know how they come up with prices that they charge, okay? And yet you're an expert on what the prices are and how these things end up getting, you know, on somebody's bill. And that's because there's no transparency in this mess. This is designed to confuse people. It's designed to hide negotiations, backdoor deals. That's the part that is the fraud and abuse that's part of the billing process that we have in American healthcare due to all of these commercial and proprietary interests. So they will actually hide these steps that they've taken to come up with these billings. They are fraudulent, they are predatory, they're putting the cost, they're cost shifting onto the shoulders and backs of the working class. And this is the corporate class putting the cost of healthcare onto the working class, and that includes professionals like nurses, doctors, and technicians. So we are not above it. We're actually the victims of this as well, those of us who work in the system, and should never see ourselves as above it. It's also abuse because it's based on the presumption that you will pay whatever it takes to keep yourself and your loved ones alive. It does not, they're not charging you based on what the service actually costs to provide. And pharma is the best example of that because they charge for their product what they think you'll pay, not what it costs them to produce the drug. So this is the mess we're getting rid of by going over this system. It's transparent and like Ron says, you can actually see the process. It's public, it's open, and accountable, and that's what they're fighting. And they'll throw any manner of obstacles our way. And like Jeanna says, you know, we'll add whatever details we need, but we need to keep it this open and transparent in the process of adding the details.
Yes, absolutely. And just to add to is that there is no transparency, not just to provider. I mean, providers like Dr. Bill and Dr. Ron, you know, they have to bill, like they need to enter those codes, but they're not like, there's no price when you're entering the codes in the computer. There's no price next to that code saying, okay, I treated this patient for atrial fibrillation, this code here, there's no price associated. So they have no idea what is going to be paid out per that diagnosis. They have no idea what's going to be paid out per that treatment. Ron might know derm, and you know, he deals with low income, so he might know a little bit more, but guaranteed it was probably more of his own research more so than just being, you know, having an easy access guide to know. So I will use the example of my own personal thing going through right now, what I did for my vision, having to go through an ophthalmologist to find out why I have a retinal hole. And they went ahead and he's like, you know, oh yeah, I'll just go ahead and take care of that in office. And, you know, I can just go ahead and laser this and blah, blah, blah. And of course I'm sitting here like, what? You're going to do what? And, but one thing that I didn't ask that after I left that office, I should have asked is, how much is this? And, you know, is my insurance going to cover this? You know, I didn't get a chance to, and me being case management with my own care, I don't expect anybody else to do this, but because I know how it kind of works, I usually go in through my insurance website through Anthem, and I'll Google or excuse me, search through their thing, the estimated cost for a procedure. Well, I didn't get to do that this time. So I have no idea the bill coming for me. It could be covered, be great if it is. It could not be covered. And if it's not, or if it's a huge, I'm about to just get that bill. And so that's the problem is that, but like Dr. Bill said, the care, you should not have to like, you know, you're not going to not get care. I mean, some people do decide to decline care based on cost. But at the same time, when you're in that situation, you're likely, your thought process like mine is not going to immediately jump to that all the time. And so unfortunately, like me, many people get that bill down the line. Okay, your insurance covered this much and you're responsible for this much, or this much. An observation stay is a good example of this too. When you get admitted to a hospital, or they say that, you know what, I want to keep you here for observation. Ooh, you know, you think, oh, okay, good. You're being cautious. I'm just going to stay here overnight, let you keep a heart monitor on me, you know, whatever. I'm just going to chill out and, you know, make sure we're good. Well, unfortunately, observation is not considered inpatient admission. And in the insurance world, including Medicare, observation and inpatient admission are two different things. And so you may get a bigger bill for an observation stay or those higher copays. So for example, insurance companies will say you have an ER copay of $350 unless admitted. Observation doesn't count as an admission. So you're still getting that $350 copay. But you stayed overnight in the hospital though. You did. So in your head, you're admitted, but you weren't admitted. So you see how ugly this system is. When it comes to billing. Now, who created that and why? I probably could find out, but I just want to paint that picture of how messed up that is. And, you know, once again, it goes into something that is a deeper conversation. We could probably spend 4 hours. We could have a healthcare billing salon one night of all the great finds, and we probably still would not be able to completely pull apart the spaghetti bowl.
Right. But we would have a spaghetti dinner with the salon, right? Like
we would have to have spaghetti.
At least we would know what the menu would be. Yeah, and there's so many, you know, there's sometimes, mostly I have no idea what prices are being charged for all kinds of different things. I mean, there's sometimes where occasionally somebody sees me, for example, I'm a dermatologist, I work in an outpatient setting mostly, and occasionally people come and see me and pay cash. And so like, I can just know what I can charge for something if somebody is for some reason paying cash. But overwhelmingly, once you get into insurance, it's like, it's really hard to know all kinds of things. And there's a tremendous number of like shell games where there'll be some bill that, that says something was the charge, but the insurance company had negotiated something else, and that's what actually will be paid. And that's also separate from what your kind of the cost sharing stuff that Jeanna was just talking about is, like what your copay will be, or your, you know, where you are in your deductible, or any of the kinds of things that, so all those words, which are like not obvious stuff to a lot of people, like what is a copayment and what is a deductible and all those things, or they only learn when they suddenly need like to kind of deal with all this stuff. And all those, the kind of surprises that are generated by these things are financially catastrophic for people. And even when they're not, there's huge source of strife, right? They're like this thing that happens, or like this is something that will happen, which is that, you know, I write, like almost all the prescriptions I write are for something generic. Not all of them. There's a few things, because there are a few things that are still on their patent. But like, if I could, like, I try to essentially write everything as generic. Like I always write out just the generic name, even for a drug where there's like only one of it available and it has a brand. Like I'll write out the generic name. But many of these drugs or things that I write prescriptions for, they're, you know, stuff that's been around for forever, cost pennies for the whatever to manufacture. But I, for example, can't always tell what will be covered or not by any different plan, or even the same plan, right? Like the same plan over time. Like even for a plan that I know, you know, I've seen the people over time, you think that you could figure out like what is covered or what tier or what this or what that, and it's almost always impossible. So what ends up happening, and this is sort of by design, is people go to the pharmacy, and this thing, which really should cost like $5 or $10 if it's cost or any relationship to its manufacturing cost, is not covered. And so then one of two things happens. So one, the patient might think like, oh, well, Dr. Ron thought I needed that, and so I'm just going to sell, I guess I'll have to sell my, like this ring I inherited from my grandmother to buy that cream that he gave me, that in fact, that cream should only be $5 anyhow. Or they'll get mad and say, why did Dr. Ron give me this not covered thing? And then he'll, like, that person will call the office, and the person working in the office will catch like an earful, and then then the person in the office will send me a text that says that thing wasn't covered, and then I'll say, oh God, well I don't know what is covered, and that can be hard to find that out. So then I'll send something else, or crazy things will happen, like it's something that's covered somehow at the pharmacy has a bigger copayment than it would cost to buy that thing for cash somewhere else. How did that happen? I don't know if people follow that.
I literally have sent people to Amazon because it is cheaper to get than using CVS, Rite Aid. And it's crazy because Amazon is dabbling into pharmaceuticals now, because they're such a big corporation, they can negotiate.
Right. So the issues with, so there are a lot of people who say, well, you know, there's a lot of problems with our healthcare system, and gosh, I'm not sure if single payer is the right way, but you know, like one of the problems is that it's like really hard for the consumer to sort out what's going on, right? And that's true. It's actually incredibly hard, but the efforts, and you know, so there's always this sort of drumbeat for price transparency, for everybody involved to be able to see the prices for things better. And while like by itself, it's hard. It's sort of hard to argue against. I wouldn't argue against that. I think that makes sense. That doesn't solve all our problems, right? And so one of the reasons why it doesn't solve all our problems is that, you know, how it's sometimes hard to figure out, like if you yourself didn't go to nursing school or you yourself didn't go to medical school, like, well, how valuable is this thing to me, right? And so because you don't know, right? So what you're counting on is the person taking care of you knows if it's valuable to you or not. But what if it's sort of, you know, there's a lot of things that they might be right at that margin. Like, would it be, wouldn't it be, would it be, wouldn't it be? But when you have a system where it's a bunch of people just kind of using that sort of consumer approach, in healthcare, it doesn't work very well. And one of the reasons is that those conversations take a tremendous amount of time, right? And that time takes away from the limited resource, which is the time that we have as people caring for people to talk about what they need, like what their care, like their, how do you take this medicine? And so it's not that value of things doesn't matter. There are things that are a waste, and you want the doctor not to tell you to do wasteful things. But the notion that you can just kind of substitute the same sort of shopping that you do, like when you just say want to try to buy a car or something, you can't even, the complexity of a human being and healthcare is infinitely more than the complexity of a car and what you want out of a car.
Yeah, and I just wanted to add to that. So you brought up a very good point with that pricing transparency thing. Like it's not like you said, shopping for a car. You're not just going to CarMax and Carvana and whatever, but you also have to think, what is your insurance going to cover? Now, if insurance never existed and you paid out of pocket for everything, may God help us all. And then maybe, sure, price transparency would matter. You could be like Southwest Airlines or whatever and have transparency, but your insurance, all different insurances cover different portions of things. So whatever the price the hospital puts up there, then you, consumer, have to go know, well, how much of my insurance is going to cover this? And that is a whole nother thing that you don't know. Is it 100% covered? How much is your deductible? Is there stipulations to that deductible? So while you may know, okay, this procedure costs $20,000, you may not pay $20,000 because you have, your insurance coverage covered that procedure better than the next person's insurance coverage. So maybe you pay $5,000 of that $20,000. The next person might pay half. The next person might pay $2,000. So while having those prices there will just let you know, see across the board, okay, this hospital may charge a little bit more than this hospital. It really, when it comes to, like Ron was saying about the car, that car price, you may not pay that same price. It's not, but you may not save the same. It's just cute. To me, it's a distraction. Yes, we do need price transparency to maybe put a little light on what's going on in the background, but at the same time, there is a much bigger problem going on there. I just want to add that in. And I see, Paul, you put a question in the chat, and then Dr. Bill, I see your hand up. Dr. Bill, was your question regarding what Ron was talking about?
Comment.
Yep.
Or comment?
Yeah.
Oh, okay. So then Paul, we'll come back to your question about the Medicare fines. Go ahead, Dr. Bill.
Oh, well, I was going to add to what Ron said, that we don't usually expect people to price out, what the general public needs are. So, like, you wouldn't shop around for, police and fire. You wouldn't shop around for, for court systems, things like whatever is a need that we generally all have, and if we stop thinking about our health as something we buy, something that we purchase, that it's something that, it's like, like driving. Okay. So when you get in your car, you're not going to, yeah, you can say, well, I'm not going to go this way because there's crappy roads that way, and there's a nice new bridge this way, and so you may be able to do that. Most of the time, you don't really have a choice. You're just going to go from point A to point B, and you're going to trust that the civil engineers involved did their best work, and none of us priced that out. So I think that's a reasonable expectation in healthcare. Nobody should be so knowledgeable, so smart. At some point, you have to give that over to the experts to know, like the healthcare experts, to know what actually is they're doing on behalf of all of us. And I'd like to bring up, if I might plug a movie. I have no financial interest in it, but it's that movie I think everyone here has seen probably many times, like I have, called Fix It Healthcare at the Tipping Point, or just Fix It Healthcare. You can go to fixithealthcare.com, watch it online. But there's a wonderful segment, and there's lots of good segments from all wonderful advocates in there. One of them is Dr. Donald Berwick, who was the head of the Center for Medicare and Medicaid Services, the CMS, under I think it was President Obama for at least a few years. And he said at one point, you know, he had a budget in the CMS of, you know, like trillions of dollars, and you know, and he said at one point he didn't know how they arrived at prices that they arrived at in hospitals. And he said, I guarantee you, you know, if I don't know how they got these prices, nobody else knows, you know, that these are trade secrets, you know. But I also guarantee you that someone like him, you know, who is advocating for just this kind of system that we're talking about with California AB 1400, you know, knows what all of the window dressings are that need to be added to the bill. You know, I would trust him and people like him to run this system on our behalf, on behalf of the public, you know, and trust that they will make those decisions that none of us could be qualified to make, you know, go and shop around for whatever generic or trade name drugs, or, you know, or any of that. So, so I think that's an important distinction.
And I think also, you know, one thing about what you were saying is that when the motive is different, so when your motive is profit and revenue growth, your decisions that you make are towards that. And that is where insurance companies are. Their motive, while they put on their websites that it is to keep you healthy, their motive is profit and revenue growth. When they go and have board of directors meetings, high-level leadership meetings, they're not asking, well, how many patients did we care for? Yes, they want to know what we call member, how many lives do we have, members do we have? But at the same time, how much revenue growth have we obtained? They set goals based on revenue growth. They don't sit there and say, oh, well, we want to make, by gosh, we want to make 20,000 people healthier than they were before. That's not a goal. Their goal is revenue growth and membership. And that's how they push membership growth, because that membership growth is revenue growth. And they also work on cost containment. Cost containment is very important. Don't get me wrong. Cost containment is a conversation you will hear in AB 1400, because healthcare is expensive, and we have to curb costs. So you hear us talk about cost savings all the time. Cost savings, yes, and we also have to sit there and say, okay, cost containment a little bit. But at the same time, like I said, you know, it is really important that, you know, we understand when you have a motive of revenue growth and profit, you make decisions on that track, okay? Because that's your goal. That is what you have to report to. When your goal is patient care and your goal is keeping a system going, like AB 1400, like we can't belly up the system, we have to keep it going. And we also have to take care of people, because we know that the healthier people are, the lower utilization is. Your lower utilization is, everything keeps going forward. And that means our goal is now a public, more broader goal, that we're not reporting back to profit shareholders. The profit shareholders of AB 1400 are me, it's Dr. Bill, it's Ron, it's all of those people. Granted, the board has to report to the governor and there are regulatory bodies, but we're the shareholders of AB 1400, each and every one of us, not just a few people sitting around a fancy boardroom. Okay, I'm sorry, Paul, your question has been sitting there for a minute. Let's get to it. Medicare fines people for applying after 65. Will AB 1400 apply? Fine people. And I actually pulled up why, when I saw that pop up, I went into the bill, and I'm in chapter 3 under eligibility and enrollment. And so it does say every resident of the state shall be eligible and entitled to enroll as a member of CalCare, which we know in our 7 basic principles. A member shall not be required to pay a fee, payment, or other charge for enrolling in or being a member of CalCare. Now, the board shall establish a process for automatic CalCare enrollment at the time of birth in California. So if you have a brand new baby, the board's going to establish that process for automatic enrollment. It also goes in to talk about college university students. But, you know, just to answer that question directly, no cost should be associated. If you're a resident of California, you shall be able to enroll in CalCare upon becoming a resident. But of course, there is a little bit, the board will have to kind of go a little deeper into that once they're formed. Once again, you know, kind of putting a little polish on that. But that is what it says directly in the bill in Chapter 3 under the eligibility and enrollment. It's like the first thing that talks about in eligibility and enrollment.
Yeah, no, that's, I mean, it's important because eligibility, just that thing alone, that idea is like such a mess. It's a tremendous mess for our current system because, you know, if you can't, you know, like, you can't like take your shirt off without changing your eligibility status in our current system, right? Like you can't just like turn left or turn right down the road and suddenly you're no longer eligible for your health plan, or you're eligible for a new health plan. But we have eligibility based on, do you have this job? Does some family member have this job? Are you a certain age? Are you past a certain age? Did you make a little more money this year? Did you make a lot of money last year? Did you make a little less this year? And all those things make you like lose your plan or be able to get a plan. And so the idea in some ways of like fees for signing up in a system where essentially everybody's in it doesn't even make sense. But of course they like want to make sure that nobody's ever charged for that anyhow, because it doesn't make sense. So I wanted to hit on something that Jeanna mentioned about cost containment, because sometimes when people encounter this idea, you know, like an idea of like a single payer bill, and they know that one of the virtues is it'll cover everybody. And there's a lot of people out there who have different views on different things, but who think maybe everybody should have some kind of health insurance, right? And so they know that it will do that, and that's a virtue, and it is. But they'll say this, which is like, gosh, our current healthcare system is really expensive. So, and it doesn't cover everybody. So if you covered everybody with really good health insurance, and that is what AB 1400 would do, that sounds like it would be incredibly expensive. And so, but it turns out that this bill has within it its own mechanisms for containment of costs, or cost containment. And actually, we were just with the Healthcare for All Los Angeles meeting with one of the bill authors who we've been meeting with regularly, Assemblymember Ash Kalra. And Ash Kalra is the principal author, like the one who really introduced the bill. And he always wants to stress that the bill that has cost containment, because there's a lot of people, like the people with the green eye shade, say like, that sounds like a really good idea. And, you know, Assemblymember Kalra, you have a great heart, but your thing will cost too much. And it turns out that that studied over all kinds of single payer bills and other countries, that in fact they cost less. But it's worth mentioning like why they cost less, or how they contain the cost of our admittedly too costly healthcare system. And so there is a few big savings. And so one of them we've already hit on, which is that global budgets for hospitals are a good way that saves systems money, and works very well. In countries like Canada, their hospitals do very well for their patients, and that costs less. And then if you look at that giant spaghetti picture that Dr. Bill put up, every time the money moves along one of those squiggly lines, like there's like a piece of the money is taken by somebody in there. And so that's the administrative simplicity, the administrative simplification of the system has tremendous savings in it. And then the other thing is that we do spend a lot, and way more than other countries, on pharmaceuticals and other stuff like that in the United States. And you know what's kind of nuts is that for all kinds of other stuff, we don't spend a lot more than other people in other countries. For example, we spend less on gasoline, you know, like the gas per gallon cost in the United States is smaller than a lot of other places. I remember a lot of places. We spend, you know, just a lot of consumer goods and things like that. We spend less, but pharmaceuticals we spend more. Like, you know, and why is that? And it has to do with a lot of like kind of the crazy kind of like market manipulations and monopoly behaviors and collusive behaviors, and then the difficulty of the multiple payers in negotiating pharmaceutical prices. But single payers are in a very good position to negotiate pharmaceutical prices and bring like that big power on behalf of the public to negotiate prices on pharmaceuticals. And so those three big things are the big cost containment. And what's amazing, what's like part of the special sauce of single payer is you can, out of that massive savings, you can cover everybody when you weren't able to cover everybody before, and you can still save money, right? Like there's still, like you still, as an entire system, you can save money for like the whole national product of the country, or the GDP of a state, or the GDP of the country that goes to this part of stuff it's lower everywhere where they have single payer and universal type systems. So that's really important, like that their cost containment is part of the bill. And the way it doesn't do cost containment is sort of the way our current system sort of tries to, but doesn't do very well, which is a bunch of like kind of over management of clinical decision making, and then cost sharing. Like that's the way our current system. And one thing that's really sad, you know, there are still, you know, we have a problem of like the Delta variant is coming back up with coronavirus, right? And there's still all these people who haven't gotten vaccinated. And we know there's a lot of different reasons why people haven't gotten vaccinated, but there are absolutely still people who haven't gotten vaccinated because they can't imagine that it could be free to that getting the vaccine is free. That our system has built into people's heads that anytime you walk through a door that has some big healthcare like thing, that somehow you and money are going to be separated from each other in some big way. That's so been sort of like we've been conditioned to believe that, and a lot of that comes, for example, from cost sharing, which has been relentlessly increasing, right? Just out of pocket expenses have continued to go up. And so people just they can't even fathom, that's also important too, to talk about, because among some people, for example, in the legislature, I hear this every so often, where they think that kind of a problem with single payer is that there's sort of like, it's not enough managed care. Like their answer to the problems in California is like more managed care. And that just like hasn't done the trick. It's sometimes pointed out as a reason why some costs in California are lower than other places, but still our costs are tremendous compared to what the rest of the world's costs are. And we still have a tremendous number of uninsured people, and we still have a tremendous number of underinsured people, and a huge number of people who just like they police themselves out of healthcare. They just say, well, I don't deserve that, or I know I won't be able to afford it, or I know I'm good. Like if I go to get this vaccine that is free, that somehow still somebody's going to find a way to charge me for something, or they don't even know, they can't even believe that something like that could be free. So sorry, that had a little bit of a rant quality to it.
Well, I want to just go off of what you were saying about managed care, because that has been brought up. I'm actually in the process, I'm studying to get my board certification for case management, right? So I'm doing all this studying, and it's currently, it applies, it's actually dual studying, because I'm using it for AB1400, because I'm getting deeper into DRGs, I'm getting deeper into capitations and payment systems, even deeper than what I knew before. So now, oppositioners, you thought I was a beast. Now, oh, wait till I get done with this, because this is a $400 test I'm only taking once. So yeah, once I get through this payment systems, I'm like, oh yeah, there's not going to be one thing an insurance company will be able to come at me that I can't counter. But managed care, one of the things, managed care is the primary here in California, right? HMO care, of course, Kaiser's the behemoth. And so managed care by principle, the principle of it, yeah, it's pretty good. The problem is, once it goes back to what is their motive? The motive right now is not patient wellness, even though I know Kaiser likes to thrive, and they have put a bigger emphasis on preventative medicine than most, but still their motive is still profit. And so if they're saying that we need more managed care, sure, we need more not profit driven managed care. But the thing is, what is that? And so that's the problem. And we don't need more regulations. Like, it goes back to that faucet I was saying in the beginning. You don't need more people tightening the faucet of care here. We already know, like Ron, you said, the citizens are tightening their own faucet because their wallets are tight. We do not need more tightening of this faucet. It is already at a trickle. You add more managed care in there. There are so many damn managed care groups in California. I think 100 and something managed care groups in California alone, California, that's it, not the United States, California. And so that is a lot of hands trickling care under managed care or HMO. And so that is the problem. I'm like, they're trickling, and you got all these people turning these faucets, making them tighter and tighter and tighter. So more managed care is not the answer here. And I know that some of these scholarly folk and people who, may or may not be at the benefit of, getting some payments from some high-end lobby people, they may not be able to see it this way because they might not have been able to apply it and see it in application. But I can tell you from application, theory is totally different than application at times. And so the theory of that they may be talking about when they say more managed care, maybe, but the theory of managed care when it first came out, the profit monster wasn't there. The profit monster hadn't bitten the HMO world when the theory of it was made. Then the profit monster bit them. And well, here we are, profit monster. And it's a big beast. I'm scared of it, actually. Dr. Bill?
Well, I hope you could come back, in your study for your care management program or whatever it is that you're doing here, Jeanna. You can come back
with certifications.
How that board certification and care case management. Come back with kind of maybe a didactic kind of breakdown of what the principles are of it. But I know, one of the principles at least is, there's such concepts as quality assurance and utilization management or utilization review that they do. So, I mean, those things are not necessarily the, kind of belt tightening, bean counting, budget driven kind of exclusion from services because of cost kind of thing. Sometimes it really is efficiency. It's an opportunity for standardization rather than, having like practices all over the place. some of them really don't make sense and are not necessarily good for patients. And you know, so I come from a practice background that was a group model that had teams of multidisciplinary specialty teams that sat down and said, hey, this doesn't make sense the way we do it. You know, this is supported by the science. Why don't we do it this way? It'll be easier for our patients to comply. We'll get better outcomes and be more efficient, you know, puts less strain on the system. Lots of things rather than just kind of like the bean counting, you know, the bean counters are applying too much pressure on us, budgetary type restrictions, that kind of thing. So I think some of it, you know, is good. And that's actually goes back to the other arguments that we've made here before about where are you comfortable getting your care? You know, is it from a single committed healthcare provider, or is it from more like a committee or even a very large group, like say university setting kind of thing? Or is it someone, you know, like the doctor that, you know, that's always taking care of your family kind of thing, you know, and trust, but you're not really sure where they get their information. You know, could be a research center, you know, what they're doing the research, that's where they get their information, you know, and of course, obviously a lot of science behind it, or somewhere in between. So so I think that has a lot to do with, you know, I wouldn't put a kind of managed care, you know, lump it into one single thing and say it's just bad because all it does is cut services. It can also provide a higher quality of care, like you said, Jeanna. When the commercial incentives are you know, curtailed or eliminated, then it can actually provide more service.
Well, exactly. And that's what I, you know, that's where I was focusing in on that profit. When you become profit driven, managed care, HMO, like I said, the theory of it was good. I think there are going to be aspects of that, like you said, that group model that will carry into AB 1400, because it is definitely shown that it works. The management, you know, or the how they, you know, regulate and things like that. But at the same time, when you remove that incentive of profit, it really does. That's what made managed care beautiful, was that, you know, when you remove that incentive of profit, that the faucets open up, the streamlines, you get your you know, your specialist visits. You don't have to worry about being routed to where the contracted rate is lower. Instead of going to the provider that could see you the fastest, you got to go to the provider that has the lowest contracted rate, thus delaying your care. That stuff is when they tighten that faucet. But if you were to open those faucets up, it would be actually quite beautiful. And it would have made my life a hell of a lot easier if I wasn't worried about you know, oh, well, we got to use this provider because it's capped first. And then I got to go to this provider and, oh, I got to negotiate this rate, or, oh, this patient is complex. And so they want a higher rate and I got to go get it approved through my medical director, and I got to take it to a one above, and I got to do this and I got to do that. That's an everyday thing as a case manager working in managed care. And so when if I were to remove that and say, you know what, this patient needs to be seen next week, this provider's not available, I found you a new provider, or what the example Ron used earlier about, you know, the cream not being covered. If he would have said, Jeanna, you know, can you find, you know, find out where this cream is cheaper, or can you give me an alternative? And if I didn't have those tightened faucets, I would definitely be able to find that. Or like I said, under AB 1400, it wouldn't have mattered to begin with. I would have just said, oh, this pharmacy said they had it in stock by Mr. Smith, you know, or whatever the patient was. But, you know, those are the things I wanted to, you know, say. But really quick, going back to also what you were saying about, you know, whether patients want a tertiary center or research center. I think coming from the community, a lot of people go to these bigger centers, not just because they're pretty or because they're a research center. It is because they affiliated that, you know, the resources are allocated so disproportionately that they want to go where they get the best care. So they know that UCLA has better resources than MLK, unfortunately, or a smaller community hospital like LA Community Hospital, which might be right down the street from them. And so under AB 1400, we're trying to pull, we're going to not necessarily even pull resources. We're just going to make sure that the people that need the resources, the hospitals, the clinics that need those resources, get them, so that the people aren't sitting there thinking that, well, I have to go to this place because they have the commercials and you see the big banners and the big billboards, you know, because they have the budget to promote that way. And so I just wanted to add that in. I think that from the community standpoint, people are going to these bigger names like Cedars and stuff like that, not because they per se want that tertiary care. People, when I tell a patient tertiary care, they look at me with a very blank face. And I'm like, higher level, higher level. But it's more so because they affiliate that big billboard with resources. And they see that this small little community hospital, you know, like, well, you know, that needs a paint job and needs this and needs that and has a lot of people waiting outside of it, you know, even though it's closer to them. So it's like AB 1400 also will bring that equity into the community hospital so that, you know, that won't be the case anymore. Granted, still, if you need tertiary care, you need that research care, you go, and you won't have to worry about a bill about it either.
Right. And the way I just mentioned, I know, Dr. Bill, you were going to ask me, but the bill has it talks about like the different line items in the budget, because it creates a fund, right? Like just like the CalCare trust fund, which pays for all the stuff. And in addition to paying for like capital outlays for institutions, and in making those decisions can send resources to places that have been starved of resources. For, you know, historical reasons that have like a racial basis, or have just like a neighborhood-based racial basis, or any of a number of different factors that have made the sort of healthcare resources unequal across our geographically. It can work on like setting that like a right, you know, something that's, a lot of these things have been really wrong for a long time. And so that's important. There's also like a special projects budget, or I think that's what it was called, special project, but something like that, that specifically also allows kind of certain payments for certain things to be more in certain areas to encourage the provision of care in those areas, like for example, in rural areas or urban, traditionally underserved areas in the state. So those are features of the bill, where so that like equity is a real value that's built into the bill, and it's a real value that's missing from our current healthcare system. So sorry, Dr. Bill, I know you had your hand up.
And you actually hit it right on the head too, for another reason which you didn't mention, which is that primary care could be emphasized with this type of system. And that's because you can empower primary care providers to do so much more for their patients. And Canada is a great example of that. They actually, Canadian primary care doctors do many more kind of, you know, like outpatient surgeries, they deliver babies, they do a whole lot more in Canada for their patients. And that actually, you know, helps people in what we call healthcare deserts, areas that are underserved in this country. It would help a tremendous amount, so people wouldn't have to go off to tertiary centers for everything. I always say, you don't want to go to XYZ when you haven't taken care of ABC yet. So you should go to your primary care provider always, always, always first, and see what they think about things, and see how it ties into your larger healthcare needs, right? And then you can go see Dr. Ron for your dermatology needs, you know. So so that's a very important thing that we have some control over. And guess what? You know, Canadians can see any specialist they want. They go see their primary care doctor first. And it's remarkable that it works that way, but it does. It just does. And that's what we're looking to achieve.
Yeah, to add to what you're saying though, you know, usually that what you're saying is how kind of like HMOs work. You have to go to the primary to get the specialty referral. But in Canada, they're not going to their primary because they have to. They go because they trust. And that is the key here. Now, AB 1400 does not talk about, that's not going to make the healthcare relationships between patient and provider. But I guarantee you, when you have better access to care and the system is not so profit driven, you will want to build a better relationship with your doctor. And like I said in the beginning with the 7 basic principles, if you don't like that doctor, you're not obligated to stay. So you get to find a doctor that works for you, maybe one that is part of your community, one that culturally knows your culture. You don't have to sit there and stick with the doctor who doesn't know you, can't relate to you. You will be able to go find that. And then hopefully also with AB 1400, opening the door, this isn't included in the bill, but opening that door will hopefully, then we'll see more providers of color. That's a huge topic that in, conversations that have been coming up around this bill is, access, what about providers of color? And, I'm hoping that maybe this will start attracting also outside state providers to want to be part of the system, or maybe a group of providers, maybe that want to serve their community and starting their own practice. One of the biggest things could have been healthcare payments. They don't have a small private practice does not have the resources to pay people to do their billing for them. They have to do it themselves, which is an extra burden. There's a lot to starting your own little practice that is required, other than just saying, you know what, I'm going to start my own practice. But when you don't have to worry about that type of billing problems, because that's a big portion of what the doctors are stuck dealing with, that hopefully may start, you might see communities of color have their own, physician groups come in and their offices and things like that, because once again, culturally competent care is very important. And I just wanted to add on to what you were saying, is that when you have a better relationship with your PCP, you kind of really you don't trust the other guys. You want to say, and I've seen this happen rarely, but I see it happen where people are saying, well, before I have this done, I want to talk to my PCP first. And trust me, it sometimes literally might be an actual surgery that they need to have right now. And they want to talk to their PCP. And I literally am pulling out my cell phone saying, okay, I'm gonna call your doctor because you need to have this done now. And I literally am telling them what's going on. I give them the phone. I'm like, here's your doctor, talk to your doctor. But that type of relationship is rare, but I like seeing it because that means you have such a trusting relationship with your doctor. And I think we're at 6:59. That's really, I think, a good place maybe to end this. Anybody else have any last thoughts, Ron?
No, I do think that's it's a hopeful place to end it, because
it's a hopeful place.
It is because, and so let's do it there. But also, just want to thank everybody for joining us. I want to give a shout out, particular to Jeanna, but also to Paul Newman, who in the last couple weekends has really put in some extra work troubleshooting our tech stuff and making sure that we had a Zoom going and that we were on Facebook Live. So Paul, thank you for all of that. And I think so thank everybody who joined us here in Zoom land and everybody out in Facebook land. And don't forget, so this coming Saturday is the 24th, and that is that Medicare for All March, right? Multiple places in California, March for Medicare for All. In Los Angeles, it's between 11 and 5. It starts at the Hollywood and Highland center area. And so encourage everybody to take part in the marches, and we'll see, but we'll still see you next Sunday.
Exactly. So yeah, 11 a.m. at Hollywood and Highland we start, and we'll finish at DeLong Pre-Park. So hopefully to see you guys there. You'll see me running around with first aid. All right. Have a good one.
Bye now.
Bye-bye now.